Today's video is on the treatment of hemophilia and von Willebrand's disease. This video's objectives are to discuss the use of DDVP in mild hemophilia A and von Willebrand disease, the use of antifibrinolytics, the use of coagulation factor concentrates for bleeding control and for prophylaxis, and then recognizing signs of an inhibitor antibody. So DDAVP is an analog of vasopressin hormone, and in large doses will cause the increase in circulating levels of von Willebrand factor and the factor VIII bound to it 2 to 3 times the baseline level. It does not, however, increase the production of these, and that's important. One of the 3 side effects is tachyphylaxis. Tachyphylaxis is the term for a waning response to a continued dose of the drug. And this is a case of this drug. As the supply of the clotting factors is consumed, the dose has less and less response. The drug can be given commonly IV or intranasally, and its side effects are water retention and headache and facial flushing and the tachyphylaxis I mentioned just now. Of the 3, headache and facial flushing is common and is the most easily treated, as this is generally rate of infusion dependent and can be treated with Tylenol and then slowing the rate of infusion. The side effect that's of greatest concern is water retention. Water retention can cause potentially life-threatening severe hyponatremia, and therefore this drug has to be used with a great deal of caution, and no free water access should be used around the dose of this drug and for approximately 8 hours after. Generally speaking, I advise families to have their children drink Gatorade or other salt-containing fluids. And in terms of IV fluids, I use normal saline, and I restrict to just maintenance fluids, or perhaps even less than that if I'm concerned about the risk of water retention. DDVP is capable of raising von Willebrand's factor 2 to 3 times its baseline, and as I mentioned, factor VIII will rise with that. However, if your patient's baseline level is too low, in the case of moderate or severe deficiency, the effect is not clinically useful, even if seen. If you go from 2% to 5%, you're having a biologically appropriate response, but you're not getting anything valuable out of it. If your patient's bleeding challenge, for example, surgery is going to be in a location where any loss is dangerous, say bleeding into the brain, or is likely to last for more than a couple of days, like say orthopedic procedure where there's a lot of bleeding in the surgery, and then there's post-surgery physical therapy, where then the tachyphylaxis of DDVP will make it less useful. So in these cases, even if a person is known to respond to the drug, it's passed over and factor concentrates are used. Antifibrinolytics are drugs which inhibit plasmin destruction of fibrin. And the 2 that are in common use in North America are tranexamic acid, which has a brand name of Listetta and is used frequently in treatment of menorrhagia in young women. And then epsilon aminocaproic acid, or Amicar. Both can be given IV or orally. And tranexamic acid is more powerful in terms of a dose response for milligram by milligram than Amicar. However, Amicar is easier to get. So Amicar is oftentimes used even if tranexamic acid may be a more powerful agent. Both are used in mild hemophilia to aid DDVP, and are used frequently in the treatment of oral bleeding, dental work, for example, and some ENT procedures. Care has to be taken to avoid this drug class, though, in boys who have hematuria. And there are boys with hemophilia who have what's called chronic benign hematuria of hemophilia. And this is a low volume bleeding into the urinary tract. And if you give this agent to a person with this condition, they will clot in their ureters and result in acute kidney injury and obstructive uropathy. Antifibrinolytics can be given either as pills or liquid, even though most adults usually prefer pills. The small size for the pills in terms of milligrams per pill makes them impractical for most adults, and so liquid tends to be used. Read the FDA guideline for further further information on that if you need. The tranexamic acid can be given as an oral pill in the form of Listetta or a liquid solution. The solution usually is compounded by a pharmacist into aqueous solution and works well, but requires a pharmacist with access to those drugs and a compounding ability. And then the pills are large, whereas the Amicar potency of each pill is small. The pills themselves are normal size. And tranexamic acid pills are substantial and are difficult for a child to swallow, particularly if they've had oral surgery recently. So the treatment of acute bleeding is done with a factor plan. The factor plans are dependent upon the nature of the injury, a high velocity injury or a fall, the potential for organ or structure damage or life-threatening bleeding, the time between the event and your treatment, and the expected compliance of the patient. For example, a person who has a fall from a stair lands on their shoulder has a risk of bleeding into their latissimus dorsi or their biceps or triceps muscle, and a relatively simple problem. A person who falls on that step and lands on their head has a more difficult problem. A person who falls on a step and tries to catch their fall and then jams their wrist has another kind of problem. The potential for organ or structure damage is an important factor. Closed or hollow spaces are a risk for ongoing bleeding and or damage from that ongoing bleeding and are a different concern than some bleed into a muscle. The time between the event and your treatment. The more time passes, the greater the amount of blood loss and the greater potential for local damage. And so then not only do I want to factor that person up, but recognizing that I may well have to do something in terms of intervening for the blood, I want to probably put that patient in the hospital for at least overnight. And I want to make sure that I have access to appropriate surgical therapy if I need. And then obviously the factor plan would have to count that in as part of the plan. And then the expected compliance of the patient. If I have a patient who lives, 2 miles away from the hospital, I can have them come back to clinic the next day. But if I have a patient who lives on a farm 2 miles away from the little town they live in, and that's 20 miles away from the next big town, and they're 100 miles away from me, then I'm going to have a difficult problem to do if I try to do them with home therapy the next day. I'd rather put them in the hospital, get them stabilized, and then do home therapy once we have a stable patient. So life-threatening bleeding risks occur in various parts of the body. And that one of the rules you need to remember about treating hemophilia is the amount of bleeding visible on the outside of the head is not necessarily reflective of the bleeding inside the head. And this can be thought of for all hollow structures of the body, but this is particularly important in the brain, as people can have ragingly nasty looking hematomas on their face and be completely normal, happy little children. They can have a small little knot, a little bruise on their face and be in deep trouble with bleeding inside their brain. So it's important when you think about head injuries or think about bleeding into the hollow parts of the body, that you recognize that the outside isn't necessarily what's going on the inside. Another thing to remember is that the muscles of the paraspinous region, particularly in adults or in adolescent boys, can hold a lot of blood. In the psoas muscles, 2 units of blood would be an easy thing for them to hemorrhage into. Same with the obturator muscles and the other muscles of the hip girdle. So in addition to the need to stop bleeding, you may need to watch for anemia. You may need to watch for local damage from all the hematoma. And so symptoms to think about with intracranial bleeding: headache, dizziness, visual disturbances, or lateralizing signs. Torso: shortness of breath, chest pain, abdominal pain, faintness from loss of blood. Back: pain along the spine, stiffness, radiating pain, and numbness. Pain on moving the hip would make me think about a back injury with bleeding. And the back injuries can be muscle. They don't have to be bony. Limb bleeding, swelling, numbness, and radiating pain. And we worry about upper arm and other areas where nerves can be compressed. So here's an example of an ankle bleed. And here, if you look at the yellow arrows and you compare the normal knee ankle to the swollen bloody ankle, you'll note that there's a normal external anatomical landmarks on this ankle. And you notice there's really not as obvious. The malleolus is swollen, the area around it's swollen, and the knee or the ankle is held in partial plantar flexion. And you'll note the x-ray. Along the green arrows, there's this lucency that's referred to as a fat stripe. And that lucency is actually blood blowing up along the space between the Achilles tendon and the other structures deep to that. And those are classic signs of a bleed in that joint. The bleed will be warm, it'll be diffusely tender, there'll be pain in the joint, pain in the affected structures that will be non-dermatomal. That is just diffusely tender. Basically, these things look like just a massively sprained ankle, and on X-ray similarly. So, treatment of an acute bleed. In Factor VIII, we most commonly use recombinant product, and the most common brand of recombinant product we use in our center is Advate, which is one of several now, but that is now still our most common. 1 unit per kilo of Factor VIII will raise the Factor VIII level in the circulation to 2%. So 50 units per kilo will make 100% correction in your factor level. And the half-life is about 8 hours. So 1 dose of factor to 100% will give you a 50% level in 8 hours, and a 25% level in 16 hours, and a 12.5% level in 24 hours. Factor IX is used in combination. Recombinant products are used particularly in children, and that recombinant brand is Benefix. And plasma-derived products are used, and one of the commonly used brands is Alpha 9 SD. Another brand that we use is Mono 9. And I tell you these brands because I want you to be able to recognize the brands, because the families will tell brand name rather than factor name. 1 unit per kilo in Factor IX will raise only 1%. So 50 units per kilo there only gets you to 50% of normal. And the half-life is a little bit longer at 12 hours. So emergency bleeding, and we're going to use Factor VIII. We dose to completely correct the deficit, and our dose is 50 units per kilo as a bolus. And remember, the nature of the injury and the time between the injury and when they get factor determines the outcome of the bleed. So we image after we give factor. This is critical. You always give factor before they leave your site. All right. After you've given the bolus, we start a continuous infusion of factor to account for the consumption of factor in the metabolic. You use metabolic consumption rate, and we try to keep the level at or near 100%. And this calculates to about 4 to 6 units per kilo per hour. Now, for a non-life-threatening bleed, we can be a little bit more restricted in our use of factor. So if we're looking at the history and we look at our physical exam findings and we think there's a risk for an organ threat, we treat per life-threatening factor procedure. If not, then you can give 25 to 30 units per kilo and consider a repeat bolus later, either 12 hours or 24 hours. And we'll continue that for 3 to 10 days, depending on the nature of the bleed. But we want to make sure the bleed is sealed completely and is had a chance to resolve. Now, with factor 9, we use the same basic strategy, but we use different calculations because we want to make sure that we account for the less recovery. So instead of 50 units per kilo, we would use 70 to 100 units per kilo. So prophylactic factor. This has been a major change in the last 15 years. The use of factor every 2 to 3 days can raise the trough level of factor to more than 1%. And this has the effect of reducing target joints. Because the target joints don't form, the joint bleeds don't cause the disability that they would have caused, and this results in children who are healthier long term. Our typical dose of factor VIII would be 30 to 50 units per kilo 3 times a week, although this can range all the way up to every other day factor, depending on the individual's kinetics. We try to schedule to spread the doses evenly through the week, and we try to do it on days of peak activity. For example, there's a soccer practice on Tuesdays and a game on Saturday, so our prophylactic schedule would be Tuesday, Thursday, and Saturday. Inhibitors are anti-factor antibodies, which are usually IgG class. They're more common in factor VIII, and they mostly occur in severe patients. And they're usually presenting with increase in bleeding or diminished response to factor doses. And what you'll notice in the kid who is on prophylaxis is that they have less minor bleeding. So not only do they have the joint bleed protection, but they don't bleed quite as much with the incidental trauma. And then somebody with an inhibitor will start having those bleeds, or they'll have a joint bleed as their warning shot. And so when you see somebody whose annualized bleeding rate goes up, or you see somebody who's having more minor bleeds than they used to have, thought's given to an inhibitor. We detect this by finding an abnormal recovery of factor, and we can find that by measuring it directly with an inhibitor assay using a Bethesda assay. So a Bethesda assay is measured when the amount of inhibitor necessary to destroy half the circulating factor in 1 ml of known normal plasma, then that's a Bethesda unit. Inhibitors are classed in terms of low Bethesda units and high Bethesda unit. So a high titer or low titer inhibitor. And they're treated, particularly when they're either persistently low or they're high, with immune tolerance. Now, the complexities of immune tolerance are beyond the scope of the video, but just to make sure you understand, this is a lot of money. Immune tolerance requires 100 units per kilo per day of factor VIII. Factor VIII's average wholesale price is about $1 a unit. So a 10-kilo child would require 1,000 units a day, or 1,000 units wholesale, $1,000 wholesale per day, and would require that for 6 months. For a bleed, Novo 7 is used, and that costs about $7 a microgram and is dosed at 90 micrograms per kilo per dose every 2 hours till bleeding stops. And so again, that 10-kilo child would require 900 micrograms at $7 a microgram every 2 hours, plus the cost of the emergency room visit. And so as I described to families, inhibitors are antibodies that consume money. So we're going to do some review questions. Go ahead and pause your player if you need to answer your question. So Tommy's a 10-year-old boy with severe classical hemophilia. He's playing Little League. He's in the on-deck circle. A batter hits a foul ball. It strikes Tommy in his right shin, inferior to his kneecap, about half an hour before you see him. Which of the following should be done first? So, of the choices here, DDVP is used in mild hemophilia, but it really is not useful at all in severe. X-rays are never done until the factor is given. We want to avoid making the local bleeding worse. Morphine may be helpful in making his pain get better, but the factor concentrate and some ice will work just as well. Benefix is a factor 9 concentrate, and that will not help a kid who's factor 8 deficient. Question 2. Bill has mild factor 8 deficiency with a 20% baseline level. Needs to have a cavity filled and to have dental cleaning. Dentist plans to do this with local anesthetic. Of the following options, which would be most appropriate for his bleeding prevention? And the answer is D. Assuming that Bill is known to respond to DDVP, the choices of B or D would be likely. However, B would result in tachyphylaxis and eventual breakdown and bleeding. Answer C would not provide adequate hemostasis. Answer E is inappropriate for minor surgery, but would be, of course, the appropriate answer for Bill if he had to have a major reconstruction of his face or had to have extensive oral surgery. So question 3. John has severe factor 8 deficiency and a knee bleed that was treated with Advate for 5 days. It's not getting better. His most recent dose was 4 hours ago, and his factor 8 level is 0. So the following, what should be most likely? And he would have an inhibitor. And this is a relatively common presentation of an inhibitor antibody. The normal dose of factor does not result in improvement when in fact it used to. From here, you could then measure the activity in Bethesda units and consider treatment of the inhibitor. All right, this is the end of this video. If you have any questions, drop me an email at jlharper@unmc.edu and go ahead and close the YouTube viewer and it'll take you back to the rest of the Prezi. Thanks. Bye.